Hey guys, Dr. K, hope everyone's doing well. This video, a little bit more for med students, a little bit more for ER residents and the ER community as opposed to the general population, but always good to listen and understand how medical training gets done. The ACGME just proposed some changes to the emergency medicine residency program. Now, for those of you who have been watching the channel, I am an ER physician. I am board certified in ER. I went through an ER residency, but that was a long time back. So I actually went through my ER residency after graduating from medical school in 1987. It was an osteopathic program. I then went ahead, and what they had in those days was a rotating internship. We did a rotating internship for 1 year where we went through all the different disciplines. We did OB, we did internal medicine, we did family medicine, we did ER, we did obstetrics, etc. Then we went into a residency program. At that time, it was only 2 years. So we only had a 2-year program at that time. So after 3 years from graduation, we were allowed to sit for the boards and actually pass the boards. Now, currently, there are programs that are 4 years, and there are programs that are actually 3 years. Now, the proposal by ACGME is that in 2027, or those residents that are entering in 2027, we'll actually have to do a 4-year program. As I said, some programs are 4 years. I know Cook County here in Chicago is currently a 4-year program. That wouldn't have a significant change. So why the recommendation? I think part of the recommendation is coming in from the importance of making it more stringent and more organized so that each of the emergency medicine physicians, residents, as they go through training, will actually have a very similar type of experience. Meaning, you could do a residency in a program that has low volume and low acuity and is in a tertiary center, as opposed to someone who goes and does a residency. It's a tertiary center, an academic center that has huge volumes. So you want to go ahead and actually be able to compare apples to apples and oranges to oranges when you are actually doing training. Now, my view is this. If you're going through a residency program, I think it's extremely important you're trained to be the best physician possible. So if that takes 4 years because of what you're exposed to and the experience that you have, then it should be a 4-year program. If you could gain all of that experience in 3 years, then it may work as a 3-year program. And there are some physicians, and I'm not being judgmental, they could go through a 7-year program and it won't make a difference. There's others that could go through a 3-year program and be very competent in what they actually do. Some of the other proposals are increased EM time overall. I think that's important. That's what you're going to be doing for the rest of your life. So to be able to go ahead with the exposure to EM is extremely important. Added requirement for low resource EDs and low acuity. I think that's important to be able to bring in or increase the standard. Increase critical care time and pediatric time. From the critical care time, I think that's important. Medicine continues to evolve. The other important factor that everyone is aware of is the fact that there are tons of boarders in the ER, right? The days of diagnosing something acutely and whisking them up to the ICU or to the floor for someone else to deal with those doesn't really exist as much as it did before in the past, and the ability for the emergency medicine physician to truly understand the complexities of critical care, I think is definitely an added benefit to the emergency room physician. We want added time for obstetrics, toxicology, and addiction medicine and EMS. I think from an obstetrics perspective, I think that's extremely important. Why? I've been through organizations, and local organizations here are all getting rid of their OB. What they're doing is they're centralizing obstetrics to one facility. So if a patient comes into the emergency room and is in active labor, that patient is not going to be transferred. So the ER physician has to be comfortable, actually, from an obstetrics perspective, to be able to deliver that patient. So I think that's an added plus for the residents, and I think that comes up more out of a necessity because of the way the healthcare systems are now being structured, and there are isolated obstetrics as opposed to everybody having an OB floor. And when somebody came in and they were over 20 weeks gestation, off to OB they went, and the ER doc did not have to deal with them. But now, if the emergency room physician is part of an organization that does not have OB in that specific facility, I think it's extremely important for the physicians to be competent in OB. In terms of EMS, the ER physicians are kind of in a weird spot in the sense that they're really responsible for that pre hospital. They're responsible for the ED portion, and they're responsible for that collaborative handoff to the physicians that are going to be taking care of the patients on the floor. Having a better understanding of the EMS component, I think, is important. Toxicology, neither here nor there, depending on what's going to happen with Toxicology Center or Poison Center. The ability to pick up a phone and talk to the Poison Centers in Chicago when I was an ER doc was extremely valuable. If that knowledge base or resources are still there, I think it's important to have a minimal level of knowledge to be able to care for people. But if that knowledge base is accessible 24/7, I don't know how necessary that actually is. They want some structured experience in acute psychiatric emergencies. Again, I think extremely important. I think that should be definitely something that is taught to emergency medicine physicians because of the structure of the health care system currently, where really the ER is my term, dumping ground for psychiatric patients. Those patients tend to stay in the ED for long periods of time, and having a true knowledge base of how to treat them, I think, is important. Airway management, always extremely important, obviously, from an EBC's perspective. That is one of the most important things. Non-laboratory diagnostics and ultrasound procedures, EKG interpretation, etc. Obviously, that's a basic, right? I mean, that's something that we learned years back. Aside from the ultrasound, that was not front and center in those days. But it is something that definitely should be learned. And then observation medicine, as well as ophthalmology, performing sensitive exams. I think all of those things are somewhat important. Primary decision maker, multidisciplinary team. That's right up my current alley for leadership, and I think that's an extremely important skill that emergency medicine physicians have to learn, because the ER doc really is the leader of the team, and they need to understand how they function as a leader, how they go ahead and actually interact with the other team members, and I think that definitely would be beneficial. Having a knowledge base of telemedicine is also somewhat important, and then transfers and transitions of care is something that we've been doing for a long period of time. So should it be 4 years or should it not? That's not for me to decide. I think the level of education and the exposure that a resident gets, how quickly they actually adapt to that knowledge base and what they're exposed to. If it can't be done in a 3-year period, then a 4-year program is actually an important piece. The only thing with emergency medicine, and I joked about this before in the past, emergency medicine gets intensive training in obstetrics and critical care, in toxicology, in airway management, in critical care in terms of cardiac and the ability to fully read echocardiograms and EKGs, etc., and they're expected to be at the level of all of the specialists. It really becomes the fact that an ER doc then should be able to be an OB-GYN doc, or should be able to be a critical care specialist, or should be able to be an ophthalmologist. I'm teasing a little bit, but I think there's a certain level, right? ER was the ability to go ahead and recognize something that's emergent, to stabilize it, and then hand it off to the true specialist. But if the ED docs are starting to be trained at the same level of those specialists, those lines get a little bit blurred. That's just my 2 cents on what they're proposing. I know I just yesterday did some training with the ED group at the medical college that I teach at, and I know those kids are gung-ho. I know a lot of kids were excited to get into emergency medicine. One of the attractive things was that it is a 3-year program, and some may look at a 4-year program and may opt to do something different. Now, there is a lot of residency spots for emergency medicine, but the burnout rate of emergency medicine is extremely high as well, so we're losing ED docs as well, so it's going to be a balance. Education, 100% important. The need to get them completely trained is extremely important, and if that has to be done in 4 years, because it can't be done in 3 years, then I guess I support it.